Hello, everyone. So I'm not going to talk too much about the mechanisms or what causes the calcification because Francesca has already covered those, but I'm just going to talk about the clinical aspects of what we actually see. So I'm a neurologist and see patients with FARS clinically. Um, so what happens in FARS? So how do we see these patients that come to us? What are the main presenting features? So they can be broadly divided into neurological movement disorders and psychiatric features, but I'll summarize the neurological features first. So they could be just movement disorders, which is the commonest presentation. It could be Parkinsonism, tremor, gait problems. There could be seizures, and that was the first case that Francesca mentioned, described. There could be speech and swallowing problems, and there are some non-specific features but they are associated with FARS disease, like headaches and TIA-like episodes, which we doubt are related directly to the condition, but they are associated in terms of the statistical prevalence. Uh, in terms of the movement disorders, the commonest things that people will come to us will be slowness, tremor, and rigidity, which is what we call Parkinsonism. So just to explain that term, so this is something that looks like somebody's got Parkinson's disease, but it is due to another cause, and it's not due to Parkinson's disease, in this case, particularly due to FARS. They will look quite a lot like Parkinson's. Their tremors might look very similar to Parkinson's disease. The stiffness in their body, which we call rigidity, is also quite similar, but there have been descriptions of more stiffness in the trunk compared to the limbs in some people. And the slowness is quite generalized, which is the bradykinesia, which is the slowness of movement, which is something that we see in Parkinson's disease, but much more severe in people with FARS. So this is the Parkinsonism spectrum, which is one of the commonest presentations of FARS to our clinics. Then there is a hyperkinetic spectrum, which is having excessive movements. So one is less movements and the other is excessive movements. In this, people can get tremor, chorea, which is dancing movements, involuntary movements. They can have cerebellar signs, which is in coordination, sort of getting a tremor when getting to the target or shaking. And there's dyskinesias, which is involuntary movements that are quite generalized in some people. And then, of course, along with the Parkinsonism, some people may not have all the other signs, but just have gait problems and imbalance and falls. So these are the usual things that lead to the detection of FARS in patients that we see. There's also a lot of other features that are seen with FARS in clinical presentations. Not everybody will have all of these features, so it's very important to understand that if you do not have these features, does not mean that you are going to have them. Everybody is slightly different, so you might, if you've got FARS or if someone you know has FARS, does not necessarily mean that they will all get these features, but they're commonly seen. So depression, anxiety, cognitive and intellectual impairment, and sometimes psychosis and dementia. So everybody is different. What we've understood is that they can present either with predominantly psychiatric cognitive features, movement disorders, or neurological features such as seizures and speech and swallowing problems. So depending on their main problem, we generally make a diagnosis based on the clinical presentation. So this is, if somebody was referred to us with a suspicion of FARS, this is what we would do. We will take a detailed neurological and psychiatric history. We will evaluate the movement disorder. We'll review the family history. And this would generally be quite a good exercise for us to get to a diagnosis, and usually we will be quite precise even with this part, but imaging is definitely very, very crucial. So the calcifications, as Francesca mentioned and showed you some scans as well, would be the very important markers for diagnosis. So if somebody's got these calcifications and a clinical history, the suspicion for FARS is very high. What we would do in terms of labs and investigations is we would generally take a blood test for looking for calcium metabolism, because you can understand that if there was problems with a gland called parathyroid or other problems with calcium metabolism, the deposition of calcium in the brain is not due to FARS, but due to other causes that can be correctable. So it's important not to miss those. So if somebody's been given a diagnosis and not sure, I mean, this is one of the things that we would definitely ensure before coming to a diagnosis of FARS. And then obviously the genetics offers a confirmation. It has become much easier these days, thanks to Professor Hulden and his colleagues who've been brilliant in establishing the genetic workup for FARS in such a good way. And usually if we find a confirmation of one of the known genes causing FARS, it definitely helps us make the diagnosis precisely. But even if we don't find the gene, sometimes we just rely on clinical and imaging biomarkers, because as you've just been informed, there are some genes we know that cause FARS, but some of them have been discovered within the last 3 or 4, 5 years. And if that is the pace of development in this field, it is still possible that we might not know all the genes that cause FARS, and we might still be looking for some if they haven't been discovered as yet, for example. So we do run a service, a movement disorder service at National Hospital for Neurology and Neurology and Neurosurgery Hospital, and we help confirm the diagnosis based on clinical lab genetics and imaging. We discussed the symptomatic treatment because this is where most of the world is at this point in time, because there is no cure at the moment for FARS. What we tend to do is discuss the movement disorder, the neurological symptoms, and offer treatments which can include advanced therapies like botulinum toxin injections, for example, for dystonia, or some specific treatments for tremor, some specific medication that can help the Parkinsonism, for example. And then we consider all these referrals, which might include neuropsychiatric, speech and language therapies, and some specific referrals based on the patient's problems. And then we follow them up as well in our clinics, all the people who have FARS, because we know this is a slightly progressive condition. The progression varies from person to person, but it can progress. So we monitor progression and offer problem-based solutions to whatever neurological and movement disorder symptoms the patients might have, and consider the same steps of referrals as and when needed. Okay, so this is from me.